Okay, guys, today we're going to talk about renal artery stenosis. Well, we're just moving along. Narrowing of one or both renal arteries or their branches. That's kind of the definition here. Most commonly affects patients older than 50 years old. Most commonly associated with the atherosclerosis, although there's other causes like fibromuscular dysplasia and some other things that we'll talk about later. Males and females are equally affected. There's a number of locations for this renal artery stenosis. Obviously, it can be ostial right there at the ostium. It can be proximal, closer to the aorta, or it can be kind of medial, but it's beyond that. It's unlikely to develop actually in the kidney or near the hilum. 5% of all hypertensive patients have renal artery stenosis. Of significant note, 40% of dialysis patients have renal artery stenosis, suggesting that the hypertension of the renal artery stenosis leads to this leads to chronic kidney damage, and thus to then to dialysis dependency. Among the renal artery stenosis patients, 25% have the CKD versus 2% in kind of all comers. 67% have a coronary artery disease versus 25% all comers. 56% have peripheral vascular disease versus 13% all comers. And this one's pretty significant here too. 37% have had a stroke prior to the age of 80 versus 12% in the overall population. So why is there all this cardiovascular risk? This is second to the heavy atherosclerotic burden that we'll talk a little bit more about, the RAS activation, the sympathetic nervous system activation, and ensuing renal insufficiency that skews all that overall fluid burden and essentially increases your fluid burden to such a degree that it causes intimal damage and hyperplasia. We'll talk about that a little bit in just a minute. So you get the onset. What are some cues for renal artery stenosis? There's a couple signs that it may be at play here. Normally, patients develop hypertension younger in their life, so if they develop it beyond the age of 50, it's considered a clue that renal artery stenosis may be at play. Hypertension associated with new onset of renal insufficiency is, of course, introduces concern for renal artery stenosis. Hypertension with repeated hospital admissions for heart failure, again, secondary to the fluid overload, and then drug-resistant hypertension being 3 agents at their maximum effective doses, suggestive of hypertension. The mechanism, this is something that was important in medical school, but will continue to be important at least through our licensing boards here, is the mechanism by which this all occurs. So it starts with renin, which is the enzyme that we're all sort of familiar with starting this process, but produced in the juxtaglomerular apparatus. It's released from the afferent arteriole of the kidney. It's released in response to low blood flow. So, for example, in this case, it's secondary to a stenotic artery, but it, of course, could be due to hypotension or acute blood loss, and that would be kind of the idea that, that's why it's built into us. But in this case, sort of artificially placed there due to the stenosis, or artificially activated secondary to stenosis. Once that renin is released, it acts upon as a plasma substrate to make angiotensin 1, converted to angiotensin 2 in the pulmonary vasculature. I think Dr. Chambers likes to ask that question a lot. And then angiotensin 2 is a potent vasoconstrictor, thus increasing the blood pressure. But that's not really the way that is most importantly affected here. The angiotensin 2 also stimulates aldosterone, which is released from the adrenal cortex. As it does so, it reabsorbs sodium and fluid in the distal tubule, increasing that fluid that's retrieved from the distal tubule, thus increasing the blood pressure. If you have a unilateral kidney, it's different from a bilateral kidney that's affected by renal artery stenosis. So here, in a unilateral kidney, the renin's released by the compromised kidney, but the contralateral kidney can make up for it. In a bilateral situation, the renin's released by the compromised kidneys, or one of the two kidneys, but there's really no mechanism for taking off that fluid, because again, all the fluid, again, kind of like almost like a sump pump system. The sump pump is pumping water back into the basement, so it's really just working against itself. The volume increases, and thus the renin now falls to normal limits because you have all this fluid on board, and so the renin is no longer activated, but still you have all this fluid on board. And this is called volume-dependent hypertension, which is essentially just this excess fluid status. Here's a diagram of imaging modalities. You can review that, but essentially we're going to talk about a couple high points. I want to make sure we get the high points here. The gold standard for studying this is duplex ultrasonography. You can calculate a renal resistive index off of this, okay? And renal resistive index is calculated as 1. It's pretty simple. 1 minus the end diastolic volume divided by the max diastolic volume times 100. And what's important about this is when the renal resistive index is above 0.8, it's suggestive of something that's intrinsic to the kidney. There's nothing that revascularization can help, and thus it's not worth intervening in this patient. in a vascular sense. You can also perform MRA. The problem with MRA is the gadolinium contrast causes that nephrotoxicity that we're aware of, and as a result, certainly we're talking about potentially compromised kidneys to begin with. Then there's renal vein sampling, and in renal vein sampling, you essentially look at the two kidneys and you decide, you measure the renin coming out of one or the other, and it can tell you which one's the producer of the renin. This is useful in perhaps a unilateral situation where there's some stenosis of both sides, but in a bilateral situation it would not be useful. This is why the imaging modality, the ultrasound, is just more useful. The clinically relevant stenosis is found in 0.5% of Medicare patients, but again, 5.5% of chronic kidney disease patients. So it is a significant contributor to chronic kidney disease. It's not purely anatomic, however. What's interesting here is that where there is clearly a decrease in renal perfusion and function, but that does not actually correlate with the degree of stenosis on angiography, meaning if you match patients that have renal artery stenosis with a patient that has fibromuscular dysplasia, and they're both identically impaired, interestingly, the renal artery stenosis patient will have a much greater effect from the stenosis than a patient that has fibromuscular dysplasia, which is essentially just a thickening of the intimal wall there. So interestingly, or sorry, not the intimal wall, but the thickening of the musculature causing the intimal wall to kind of invade into the lumen. So interestingly, the stenosis itself between the two processes, if that was all that was at play, you'd expect the same effect from the two processes on the kidney, but that's just not the case. CKD advances much more significantly in the context of artery stenosis. There's a couple issues that are at play here. There's chronic changes that occur, and we'll kind of blow through these pretty quickly because they're not too important in the context of what we need to know, but I do want to just introduce the topics. One will be here. You have all these, of course, just like everywhere, you've got renal microvessels that are susceptible to hypertension and intimal damage. They're also susceptible in the kidney to additional things, which we're pretty well aware of, which is low flow ischemia, low shear stress, and then when LDL, interesting, when LDL deposits on them, it develops this oxidative stress, and we'll talk about it in just a second here. The endothelial dysfunction with increased oxidative stress, due in part to that low density lipoprotein deposition, can increase reactive oxygen species, which, as we all know from all these tests we've taken before, is just a bad thing, right? So reactive oxygen species are just bad. And so it can cause these essentially endothelial dysfunction, and it can cause deposition of further atherosclerotic deposits advancing the renal artery stenosis. And then renal artery stenosis decreases the bioavailability of nitric oxide, which causes that the dilation, right? So it leads to, instead of leading to the formation of this pre-oxidant peroxynitrate. What's important about this is basically that you can't dilate, and you start getting these cofactor accumulations of these cofactors and metabolites, or I'm sorry, these cofactors, and as a result of that, you're starting to accumulate toxic substances instead of what you want, which is that nitrous oxide that should be dilating renal vessels. So again, the RAS is overactivated, so an ACE inhibitor disrupts this. This makes sense that if you're able to prevent angiotensin 1 from converting to angiotensin 2 in the lungs, that you're going to have this essentially at least some sort of interruption of the cycle. So a patient that has very high-grade bilateral stenosis, or CKD 3 and 4, this can actually lead to renal failure because it's so high, it's so overactive that essentially, again, you're just pumping. It's just like the sump pump. You're pumping the water right back in. It can actually burn out your kidneys. So so it's been discovered that an ACE inhibitor utilization is really one thing that can really significantly inhibit that. Interestingly, a setting, and this kind of makes sense because, again, the main mechanism of renal artery stenosis is atherosclerosis, that utilization of statins do effectively undercut atherosclerotic accumulations as well. And there's a graph here. This graph demonstrates that, as you see that on the left side, it's actually that's not a good thing, it's a bad thing, right? So it's a progression of kidney disease. So in the absence of statin therapy, damage to the kidney advances fairly significantly, whereas with statin therapy, it advances slightly less aggressively. Operative management, we'll talk about this, a couple of good options, a couple of bad options here. Meta-analysis of 210 poorly controlled hypertensive renal artery stenosis patients, each of which was on aspirin, as well as well as a statin and 3 antihypertensive agents. They were included in the study. So these are 3 medically optimized patients, or medically, I guess, attempt at optimization patients, but they weren't able to achieve adequate blood pressure goals unless they were entered in the trial here. Relative to medical management, operative intervention led to slightly better blood pressure control, so 7 systolic and 3 diastolic reduction on the millimeters of mercury. But what's interesting is that at the 1 so that's kind of in the short term, but at the 1 and 3 year marks, there was fewer antihypertensive agents required, fewer cardiovascular complications, and slowed renal failure trajectory. And that's probably the key features. These people are not driving towards dialysis at quite the rate that they were before. You can perform an open renal bypass, and here's some options for that. Essentially, just anything that we do to either make it open or cut out or somehow resolve the issue here. All these open interventions, however, are pretty significantly inferior to endovascular ones now, and so we don't really do them. We'll talk about why. Open surgical revascularization can result in durable relief of renal artery stenosis, but it probably will not. So it's really only 10% effective. It can work, but it probably will not. So for that 10% that it's effective for, obviously it's worth the intervention. Unfortunately, there is this 30-day mortality postoperatively. It can reach 10%. So the argument obviously is thus negated, because now you say 10% can benefit, but 10% will die. Instead, balloon angioplasty and stent is far better tolerated and incurs less morbidity. So let's talk about that. So if you do an angioplasty and stent, the cure is still not the standard, so it's like 5 to 35%, but a significant reduction in the hypertension is likely. So in this case, again, we're not going to get cure. We're not going to get these people off their antihypertensive agents and back into within normal limits and looking great. Again, but what we can do is get them at least significantly down off their antihypertensives now that they can be in goal. So they're still going to be hypertensive patients, but not nearly the way they were before. There's much less morbidity, okay, so 5.6 than open, which is 12 and 23%. And we'll kind of rate that right here. So here, in the renal artery angioplasty and stent, if you see the top line there is endovascular, and the one below it is an open intervention. And that's just of a combination of open interventions over some different collected data. I just used the ones that in the book here, and then I kind of modified a couple of them to match what's also in some other literature. So in reduced morbidity, the endovascular, in that kind of category, endovascular interventions result in 5.6% postoperative morbidity, and that's within the 30-day window, whereas in open interventions, 12 and 23% in the 2 studies cited here. In the mortality, however, this is where it really shines. Endovascular is cited as 0% in Savistans, but most studies cite something a little bit higher than that, like 0.4 is the highest. So I put that kind of as the max, just to compare to, again, 9, 8, maybe 10% in the open category. So again, this is definitely inferior, or open is definitely inferior in the open category. Or sorry, open is definitely inferior in the mortality compared. So for those interested, the technical procedure itself of endovascular stenting and everything is described in chapter 62, right at the end there, and you can look to your heart's delight. I don't know if it does a lot of good for me to describe it here, but basically, basic principles here. Make sure you understand the RAAS sort of axis, understand how that works, understand where ACE inhibitors come into play, understand that statins are good, understand that endovascular is far preferred over open, and also understand that in the endovascular group, you're going to create a lot of solutions, but not the solution. Okay, you're going to fix a lot of people, you're going to repair a lot of people, but you're not going to fix them to brand new again. With those expectations, and if you understand kind of the rest of the content here, I think you'll be all squared away. Thanks for listening. I'll move on to our next topics here.